Hello everyone, Professor Bake here. In this lecture PowerPoint, we're going to cover the respiratory system disorders. Please review your respiratory system A and P lecture video before you watch this one so you can kind of understand the disease processes better. So today we're going to connect the disease processes to what you'll see in patients. We're going to talk about how these conditions affect airflow, gas exchange, oxygen delivery throughout the body. Because remember, the GAP acronym, right? Gas exchange, you want oxygen delivery. These are all the functions of your respiratory system. These are the learning objectives. So the lesson is basically divided into talking about, first we're going to talk about infectious respiratory diseases. Then we're going to talk about obstructive lung diseases, then vascular lung diseases, and then finally we're going to wrap it up with respiratory emergencies. So let's start off with our infectious lung diseases. These conditions are caused by organisms like viruses or bacteria that affect the respiratory tract and interfere with normal breathing and oxygenation. So let's look at these a little bit more, right? These disorders occur when microorganisms like bacteria, viruses, or fungi invade the respiratory tract. We generally divide them into upper respiratory infections such as a common cold, sinusitis, croup, epiglottitis, and lower respiratory infections like pneumonia, TB, RSV, SARS, and COVID-19. Lower respiratory infections are usually more serious because they directly affect the lungs and interfere with gas exchange. Because remember, gas exchange happens in the lower respiratory tract. For example, pneumonia causes fluid and inflammatory debris to collect in your alveoli. This makes it harder for oxygen to diffuse into the bloodstream, leading to hypoxemia and respiratory distress. Many of these infections, they are highly contagious, spread through respiratory droplets. That's the reason why we put patients on droplet precautions. Viral infections can also damage the respiratory tract, mucosa, and weaken the ciliary escalator, increasing the risk for secondary bacterial infections. In severe cases, these infections can, progress to acute respiratory distress syndrome, sepsis, or multi-organ dysfunction. These diseases are especially dangerous for young children, older adults, and immunocompromised patients. So these are your upper respiratory tract infections. I kind of created this like a cheat sheet so you can print it out, download it, and kind of review these and keep it as a guide to study about these infections. So here we're going to look at several common upper respiratory tract infections, sorry, like infectious rhinitis or the common cold. It's usually virus and causes inflammation, congestion, and increased mucus production. Sinusitis is often a secondary bacterial infection. This develops when your sinus drainage becomes blocked. It leads to facial pressure and pain. That's the difference between the common cold and sinusitis, is the facial pressure and pain. Croup is common in young children. It's recognized by its characteristic barking cough and inspiratory stridor. This is caused by upper airway inflammation. Epiglottitis is much more serious because it's the swelling of the epiglottis, and it can rapidly obstruct the airway, making it a medical emergency. Influenza, which is our flu, affects both the upper and lower respiratory tract and usually presents with a sudden fever, body aches, and severe fatigue. Most of these infections are treated supportively, although bacterial infections would require antibiotics and severe airway obstructions may require emergency intervention. Now let's talk about the lower respiratory tract infections. These tend to be a lot more serious because they directly affect lungs and the gas exchange, right? So, for example, bronchiolitis, most commonly caused by RSV, is especially common in infants and causes inflammation and narrowing of the small airways. This leads to wheezing, coughing, and respiratory distress. Pneumonia occurs when fluid and inflammatory debris fill the alveoli. This makes it difficult for oxygen to move into the bloodstream. Remember, we talked about the diffusion of oxygen into the blood in the alveolar level. So this is where it causes the biggest problem. Patients often present with a fever, shortness of breath, and productive cough. COVID-19 can range from mild symptoms to severe respiratory failure. In severe cases, the inflammatory response can become excessive, causing widespread lung damage and potentially can progress to acute respiratory distress syndrome. Treatment for these disorders is often, like upper respiratory disorders, supportive, but in severe cases would require oxygen or even mechanical ventilation. Now let's look at a few more severe lower respiratory infections, right? For example, SARS. This is caused by the coronavirus that we all have heard of, right? That initially presents like the flu, but can quickly progress to severe hypoxia and respiratory distress. TB is a chronic bacterial infection. This is caused by the Mycobacterium tuberculosis. It can remain dormant for years before becoming active. That's the reason why we do skin tests to see if it's there, right? If it's present there, laying dormant. Active TB commonly causes weight loss, night sweats, fever, and a productive cough that can contain blood. Treatment requires long-term multi-drug therapy. Anthrax is a rare but serious bacterial infection that releases powerful toxins, and this can lead to respiratory distress and sepsis shock. Early recognition and treatment are critical because these infections can rapidly become life-threatening and end up in ARDS, acute respiratory distress syndrome. So now let's talk about those were all our infectious lung diseases. Please review those cheat sheets, print them out, use them as study guides. These will really help you. So now let's talk about obstructive lung disease. Obstructive lung diseases are categorized by airway obstruction. This airway obstruction interferes with normal flow of air in and out of the lungs. It can result in decreased ability to expel the air effectively, which can lead to air trapping. Increasing residual volume, because remember the residual volume is approximately 1,200 milliliters. You don't want that to be excessively high. So this is basically the air remaining in the lungs after maximal expiration. After you exhale completely, that's the air remaining in your lungs. It can also lead to elevated carbon dioxide levels in the body because now you're retaining CO2 because you're not able to breathe in and out. So the key obstructive lung diseases, why are these even important? That's the thing, right? They interfere with the quality of life. For example, COPD can cause death, may cause cardiac complications, chronic hypoxia. And the key obstructive lung diseases are asthma, COPD, cystic fibrosis, bronchiectasis, obstructive sleep apnea, aspiration, and lung cancer. And these are the ones we're going to talk about next. So cystic fibrosis is a genetic defect. It causes thick, tenacious mucus and obstructs the airways and ducts. This can lead to permanent lung damage and malnutrition. It's an autosomal recessive disorder. It's from involving the CFTR gene. Usually you'll see salty skin, staturia, chronic cough, failure to meet growth milestones in children, right? And it's diagnosed by using a sweat test and genetic testing. Treatment involves chest physiotherapy, replacement enzymes, and bronchodilators. So now for lung cancer, basically it's a chronic irritation, leads to metaplasia in the epithelium. Tumors obstruct the airflow and can cause pleural effusion or the paraneoplastic syndromes that we talked about in our cancer lecture, right? So these tumors basically obstruct the lungs, and so they're considered obstructive lung diseases. The causes are primarily smoking, 90% of the time, and industrial carcinogens like asbestos. Signs and symptoms include persistent productive cough, dyspnea, wheezing, and hemoptysis. It's diagnosed using CT scans, MRIs, sputum cytology, and biopsies. Treatment will include surgical resection of the tumor, chemotherapy, radiation, and photodynamic therapy. Aspiration is basically passage of food or fluid. In any passage of food or fluid, or objects into the trachea, which cause a physical obstruction or chemical pneumonia, we call it. Depressed swallowing, gag reflexes. Example from a stroke. People who have stroke, they have a depressed gag reflex. So if something goes down, that's their defense mechanism. They gag on it so we can push it back out. But with people, who have had a stroke, sometimes they have a depressed gag reflex. Signs and symptoms include choking, coughing, marked dyspnea, stridor, and tachycardia. So diagnosis is clinical observation. Is basically if a patient is aspirating, you see them like this, they're aspirating, that is your clinical manifestation. Okay, they're choking. Obstructive, the treatment, Heimlich maneuver, and oxygen if they need it, and supportive therapy for inflammation. Obstructive sleep apnea. The pathophysiology of that is that the pharyngeal tissues collapse during sleep, causing repeated momentary cessation of breathing. So they have apnea while they're sleeping. Okay, and it's common in men, older age, and those with a BMI greater than 30. Signs and symptoms are loud snoring with intermittent gasps for air and daytime drowsiness. So it's difficult to detect because when you're sleeping, you're not monitoring your symptoms, right? So it's people around you who sleep in the same bed as you or the same room as you would hear the loud snoring and intermittent gasps, right? But if when they wake up in the morning, they're extremely tired because they didn't have any gas exchange happening, right? They didn't have any oxygen coming in, and so now they are hypoxic and they're tired, fatigued, and they end up with daytime drowsiness. Diagnosis is sleep studies. Treatment is a CPAP machine or other appliances that will help them keep their airway open when they're sleeping. So with asthma is a periodic reversible bronchial obstruction due to mucosal edema. So it causes bronchoconstriction and thick mucus that basically obstructs your bronchiole. So this can be caused by hypersensitivity, extrinsic factor. For example, something outside, you're allergic to something and, you have a hypersensitive reaction to it. A hyper-responsive tissues are intrinsic, triggered by stress or irritant, something inside that, for example, stress or an irritant, and it triggers that. Signs and symptoms will include cough, marked dyspnea, wheezing, and labored breathing. This is diagnosed for clinical symptoms and pulmonary function tests. They're treated with bronchodilators and glucocorticoids. And so basically when people have severe asthma, exacerbation, they're given steroids to reduce the inflammation. So the bronchioles are not so constricted and they open up. Then finally, let's talk about COPD, chronic obstructive pulmonary diseases, sometimes referred to as a COLD, chronic obstructive lung disease, and is COLD, basically, chronic obstructive lung disease. It's a group of common chronic respiratory disorders characterized by progressive tissue generation and obstruction in the airways. Remember, it's chronic, right? People live with this their whole lives. It is debilitating. It significantly interferes with a person's ability to work and function. And eventually, it leads to respiratory failure due to severe hypoxia or hypercapnia, and that's when they get admitted into the hospital, right? In many cases, it leads to the development of cor pulmonale, which is a right-sided congestive heart failure, which results from this lung disease. So some of the different types are emphysema. Emphysema is the obstruction, characterized by the destruction of alveolar walls and septae, including large permanently inflated air spaces. The breakdown of alveolar walls results in a loss of surface area for gas exchange. So if you don't have enough surface area for gas exchange to happen, then you have the loss of pulmonary capillaries, which affects perfusion. So now gas exchange won't happen because you're losing, you have a loss of pulmonary capillaries, where the gas exchange happens. There is a loss of elastic fibers, and which significantly impairs the lung's ability to recoil. Because remember, we said we want the lungs to expand and recoil, and this debilitates that ability. The destruction of these structures leads to air trapping, increased residual volume, which causes overinflation of the lungs. Over time, this can result in permanent fixation of the ribs and inspiratory position, commonly known as barrel chest. And that's the reason why we notice the barrel chest, right? The diameter, from the side and the front, the ratio is off. Advanced emphysema causes adjacent damaged alveoli to coalesce into very large air spaces called blebs or bullae. Cigarette smoking, what causes it? What's the etiology? Cigarette smoking is implicated in most cases because it increases the number of neutrophils in the alveoli and the release of elastase, which breaks down elastic fibers, right? We want them to stay elastic. We don't want them to lose that elasticity. Genetic factors can also cause this, specifically a deficiency in alpha-1 and antitrypsin, and this can contribute to early development in some non-smokers. Not everybody who has COPD, emphysema is a smoker, right? Exposure to air pollutants is also a predisposing factor, right? So it could be genetic, it could be cigarette smoking, or it can be air pollutants. What the signs and symptoms that you're going to notice are basically, it's an insidious onset. It starts with dyspnea on exertion and progressing to dyspnea at rest. Now, dyspnea, when you're, having difficulty breathing on exertion, is difficult to detect, right? I mean, you're exerting yourself, so okay, I'm out of breath, okay? I'm going up a stairwell, hey, I'm totally out of, shape, and then I start breathing really heavy. It's normal. But if I'm sitting down on a couch and watching television, relaxing, and all of a sudden I can't breathe properly, I'm having difficulty breathing, then that's concerning. Right? So hyperventilation is also a sign and symptom of this with prolonged expiratory phase. So you're hyperventilating and you're exhaling really long. Okay? Use of accessory muscles. Bad thing. Always a bad thing for breathing. And assuming a tripod position. What is a tripod position? When you're sitting up, leaning forward with hands on the knees. Okay, clubbed fingers. You also, in secondary polycythemia, may develop as compensation for chronic hypoxia. You'll notice the clubbed fingers, like the curved fingernails. So how is this diagnosed? This is diagnosed through chest x-rays, showing overinflated lungs and flattened diaphragm. Pulmonary function tests will show us the increased residual volume and total lung capacity, but decreased forced expiratory volume and vital capacity. It's treated by, if you're a smoker, smoking cessation, avoiding, if it's because of irritants, avoiding the respiratory irritants, pulmonary rehab, including learning pursed lipped breathing to maximize expiration, bronchodilators, antibiotics, and oxygen therapy, as the condition advances. Lung reduction surgery may be helpful in some cases to reduce the air trapping. Chronic bronchitis involves significant changes in the bronchi resulting from constant irritation from smoking or exposure to industrial pollutants, right? The bronchial mucosa is chronically inflamed and swollen. There is hypertrophy and hyperplasia of the mucosal glands. This leads to increased secretions and a decreased number of ciliated epithelium cells. This chronic irritation can lead to fibrosis, thickening of the bronchial walls, which further obstructs airways because now you have thick bronchial walls and they don't open and close as they should. Low oxygen levels are common, and secretions often pull distal to obstructions, making them difficult to remove, and they become prone to infections because the secretions just stay there, right? An etiology of it is a history of cigarette smoking, big one, or living in an industrial area with heavy smog. Heavy exposure to inhaled irritants can leads to inflammation and frequent infections because of the constant secretions just staying there. Signs and symptoms, you have constant productive cough, which is the hallmark sign of it, right? Tachypnea, rapid breathing, and shortness of breath. Secretions are thick and purulent. Patients may appear cyanotic and sometimes referred to as blue bloaters. Severe weight loss and signs of cor pulmonale, systemic edema. Cor pulmonale is systemic edema. Often develop as as this progresses. It's diagnosed through, based on persistent productive cough for at least 3 months in 2 consecutive years. That's how it's diagnosed. Pulmonary function tests are used to evaluate airflow and obstruction. Because remember in our previous, the funnel, we said, we check symptoms, then we take more specific tests, then even more specific tests. And that's how all these diseases are diagnosed. It's treated through reducing exposure to irritants, prompt treatment of the infection with antibiotics, use of expectorants, bronchodilators, and chest physiotherapy, where including postural drainage and percussion, which helps to break up that thick mucus, and so people can cough it up. Low flow oxygen and nutritional supplements. Remember, we do not give patients with COPD high flow oxygen because that can kill them. Then we have bronchiectasis. Bronchiectasis is typically a secondary problem that develops in patients with conditions like cystic fibrosis or COPD. Its patho is that it's irreversible. It's an irreversible abnormal dilation or widening of the medium-sized bronchi. Recurrent inflammation and infection will lead to weakening of the muscle and elastic fibers in the bronchial wall. And in these dilated areas, large amounts of fluid pool because now they stay inflated. And so fluid will pool in them and they become infected, by organisms like streptococci, staphylococci, or H. influenzae. This creates a cycle of infection, loss of cilia, metaplasia, and epithelium, which further interferes with removal of fluids because now you have those inflated bronchioles and the fluid is staying there. Even the chest physiotherapy is going to be difficult to help them because they need to cough it up, right? So often it's secondary to cystic fibrosis or COPD. It can result from childhood infections, aspiration of foreign bodies, or congenital weaknesses in the bronchial wall. What signs and symptoms are you going to see? You're going to see chronic cough with production of copious amounts of purulent sputum, 1 to 2 cups full per day. That's a lot. Foul breath is a huge sign. Dyspnea and hemoptysis, right? This is blood in your spit. And this is because it's been pooling there and gas exchange happens there. And so you're going to find blood in it. Rales and rhonchi can be heard in the lungs. Systemic signs will include weight loss, anemia, fatigue. How do we diagnose it? Clinical presentation of chronic purulent sputum production. Because remember, all three of these are chronic. So these are things that people are dealing with and they don't realize it's serious. Imaging is used to identify characteristic widening of the bronchi. So when they do the chest x-ray, they do the imaging, they're going to notice wide bronchi, right? Because they stay dilated. Treatment, if it's infected, antibiotics, bronchodilators, and intensive chest physiotherapy. This will help remove secretions and reduce the severity of the infections. So now let's talk about vascular lung diseases. Vascular lung diseases involve problems with blood flow or fluid buildup in the lungs, which directly interferes with gas exchange. Two major examples are pulmonary edema and pulmonary embolism. Pulmonary edema occurs when fluid leaks into the alveoli, most commonly due to left-sided heart failure. Remember, left-sided lungs. As fluid fills the air spaces, oxygen diffusion, it becomes impaired. And patients develop shortness of breath, crackles, frothy sputum, and severe hypoxia. Pulmonary embolism is when you get a clot, usually originating from a deep vein thrombosis in the legs. It travels to the pulmonary arteries and blocks blood flow. Small emboli could cause mild symptoms, and large emboli can lead to severe respiratory distress, shock, right-sided heart failure, or even sudden death. That's why PEs are very, very dangerous. Both conditions are medical emergencies because they significantly reduce oxygenation because now you're filled with fluid, right? And you have vascular issues, so no gas exchange is going to happen. And they place major stress on the cardiovascular system because if the blood is not getting oxygenated, the cardiovascular system is not going to be able to function. So vascular lung diseases are these two, pulmonary edema and pulmonary embolus. Pulmonary edema occurs, like we mentioned, when fluid accumulates in the interstitial spaces in the lungs. This most commonly, like we said, happens with left-sided heart failure, blood backs up in pulmonary circulation, and increases hydrostatic pressure. When hydrostatic pressure increases, as we mentioned in our fluid and electrolyte lectures, what happens? It pushes the fluid up. So as the fluid leaks into the alveoli, oxygen diffusion becomes impaired. Lungs can't expand. It becomes more difficult because now you have fluid over there. Patients will present with difficulty breathing, orthopnea, right? They have to sit up like in a tripod position to breathe because they can't lay flat and breathe. Crackles or rales, frothy sputum, and cyanosis. So in severe cases will require oxygen therapy and even mechanical ventilation. Pulmonary embolism, like we mentioned, occurs with clot formation, usually from a DVT, right? They originate in the legs. Risk factors, immobility. That's the reason why we, really focus on moving our patients, right? Providing them mobility because you don't want them to sit and develop a DVT, lay and develop a DVT. Surgery. So surgery can cause blood clots in the deep veins. Trauma and dehydration can also do it, right? Patients could experience sudden chest pain and dyspnea, tachypnea, and hemoptysis, blood in the spit. Large emboli can rapidly lead to shock, right-sided heart failure, or sudden death. Treatment includes oxygen, anticoagulants to break up the clot, fibrinolytics, to break up those clots, and preventative measures like compression stockings and early ambulation. Now let's end by talking about respiratory failure, right? If not all else fails, then a patient will experience respiratory failure. ARDS, acute respiratory distress syndrome, right? Failure are both severe respiratory emergencies. ARDS is caused by inflammatory lung injury, while ARF is the clinical state where breathing can no longer sustain life. Acute respiratory failure occurs when the respiratory system can no longer maintain adequate oxygenation or remove the carbon dioxide effectively. Because remember, guys, this blood that gets oxygenated goes to the heart, and the heart circulates it throughout your body. So if it's not getting oxygenated, nothing in your body is getting oxygenated. So this is life-threatening because it can lead to severe hypoxia and hypercapnia, retention of CO2, and can quickly progress to cardiac arrest if not treated. ERF is identified by critical ABG changes, including PaO2 less than 50 or PaCO2, partial carbon dioxide greater than 50, and a decreased pH, which shows acidosis. This indicates respiratory acidosis, right? So as carbon dioxide builds up, patients develop a headache, they get confused, they're lethargic, and they have decreased neurological function because remember, you need the proper pH amount, to be for neurological function. Your brain needs a proper pH in the cerebrospinal fluid. The heart also becomes stressed as it tries to compensate for this low oxygen because it's pumping, but the heart muscles also need oxygenation to be able to pump properly and work properly. Everything needs oxygen in our bodies. ERF can result from chronic lung disease like emphysema, acute events like PEs or pneumothorax, neuromuscular disorders that weaken breathing muscles, or CNS depression caused by, for example, opioids, narcotics, or sedatives when you have opioid overdose, right? Patients often present with rapid labored respirations and signs of severe respiratory distress. You will be able to see it. You will know right away. Treatment focuses on correcting the underlying cause. Whatever is causing it needs to get treated. And we provide supporting oxygenation, and they might even need ventilation. Often with supplemental, these both might be needed. And infant, now we're going to talk about infant respiratory distress syndrome. We talked about adult one, right? And we talked about respiratory failure. So now infant and adult respiratory distress syndrome, ARDS or IRDS. These involve severe impairment of gas exchange, decreased lung compliance, because remember we said we need lung compliance. We need the lung to expand and recoil. And so they become, this difficulty in expanding can cause ARDS. In both conditions, the hyaline membranes form within the lungs and contribute to severe hypoxia. IRDS primarily occurs in premature infants because their lungs are not mature enough to produce adequate surfactant. Premature babies do not have surfactant. So without the surfactant, the alveoli collapse during expiration, making breathing extremely difficult and energy consuming. These poor little infants often present with nasal flaring, where the nose, you see the flaring, chest retractions. That's right. It's a really bad thing to see retractions. We never want to see it. Grunting, cyanosis, respiratory distress shortly after birth. Treatment will focus on supporting them with oxygen, with the CPAP, and mechanical ventilation, and administering synthetic surfactant. ARDS is the adult respiratory distress syndrome, called shock lung or stiff lung, occurs after severe lung injury or, for example, like in car accidents, or systemic inflammation that can causes could include sepsis, severe infections, aspirations, trauma, or inhalation injuries, like you inhale something and it injures your lungs. Right? Damage to the alveolar capillary membrane allows fluid and protein to leak into the alveoli, now severely impairing oxygen diffusion. Patients will develop rapid shallow respirations, hypoxia, crackles, and respiratory distress, and this can very quickly progress to respiratory failure. The major difference between these disorders is basically the underlying cause. IRDS is mainly due to surfactant deficiency in premature lungs, while ARDS results from inflammatory lung injury in critically ill patients. So these are a lot of respiratory diseases we kind of talked about. I know it's a lot of information. Please fill out the cheat sheets, review them, complete your readings, supplemental readings in your module, and look at the key points document. Fill out your study guide. You can use these to help you through, to understand these disease processes. And remember, respiratory disorders can seem overwhelming at first, but if you focus on airflow, gas exchange, and oxygen delivery, the disease processes that we learned will start to make a lot more sense to you.